Okay, welcome everybody back to another Australian Neonatal Lectures webinars. And today I have the great pleasure to introduce Associate Professor Anup Katheria. He works in San Diego in the US, and he's done lots and lots of work around resuscitation, anything just close to birth. And his resume and his publication list is quite sort of impressive. He's going to talk a lot about delayed cord clamping and issues in oxygen next week at Cool Topics. I think it's next week or the week thereafter. So today, because he was on this list, I said, oh, well, maybe talk about something which is not at Cool Topics. And Anup suggested to talk about, which I thought was really appropriate because we've all been doing it and thinking about it and gaining experience, sort of the non-invasive way of giving surfactant. So Anup, over to you.
Yes, thank you. And yes, I look forward to hopefully seeing at least some of you in a few weeks. I'm always excited when we can get some more Americans across the ocean there to visit Australia. So let me share. I'll just do it this way. This might work. Okay. All right.
Yeah, all good.
Is that sharing? Perfect. Okay,
yeah.
Great. So thank you, Kurt. You've been doing a great job, by the way, organizing all kinds of talks. So I've been able to go back and review them. So looking forward to it. And then just two disclosures. I'm a PI of one trial that's completed that I'll be presenting that was funded by Casey, and a new one that I'll mention briefly. But again, this topic is it's a high overview. So I promise not to give any sort of biases as to one being superior. We're like most researchers trying to sort of understand this better. But sort of to frame this topic of non-invasive surfactant, I wanted to take a step back and just sort of talk about what are some of the alternatives, going over some of the current evidence. And then I just to highlight, there are a lot of new trials that are up and coming. I'm highlighting some of the large ones, of which some are occurring in Australia as well. Just really quick, Julie, I sent this slide an hour ago. We had the pleasure of having Alan Job in San Diego, who moved here recently. And many of you have worked with Alan or read his work on surfactant. And I just think kudos to one of the leaders who's still been active, believe it or not, working with researchers like Graham Puglisi and others. And many of you have known him. So happy to see that he is still alive and well. So just to frame the evidence currently, I think we all have seen these meta-analyses. This is the sort of recent one, or semi-recent now, by George Schmolzer, a few others that have looked at the major trials supporting the benefit of using nasal CPAP over endotracheal intubation and reducing the outcomes of either death or BPD composite, or sort of these individual outcomes. And we've all, in our NICUs, I'm pretty sure to date, have moved that change in practice. We don't routinely intubate all of our preterm babies because we know that CPAP is effective in these outcomes. But I want you to sort of highlight this in terms of looking at the forest plot here and the diamonds. Yes, they are statistically significant, but I think now that sort of to frame this talk, the next step is how do we move the needle even further and better support babies with surfactant, potentially by giving them surfactant non-invasively, where we can avoid the ill effects of mechanical ventilation and still treat their RDS. And I don't know if Peter is going to join this talk, but I'm sure many of you know his work, which has really highlighted the benefits of CPAP, but also the caveat that CPAP failure is harmful in babies that don't do well. And looking at some of this data of over 10,000 infants at different gestational ages, looking at the higher intubation rates. But when you look at this sort of shaded gray bar here of CPAP failure, these are the babies we don't always pay attention to in the large RCTs. But the smaller gestations have a high percentage of babies that still have CPAP failure that we still need to improve on. And the reason that's important is CPAP failure is not benign. If you look at outcomes such as death or BPD or major morbidity, these are at least increased, even when you adjust them for things like gestational age, by 1 to 2-fold greater. And so, yes, while it's good to start a baby on CPAP, when those babies fail, those outcomes are not benign. And I think that's important for us to think about when we're trying to use CPAP early and optimize this potentially with non-invasive methods of surfactant delivery. So just to frame that. Now, getting into a little bit of the nitty-gritty with these different subgroups here is there's been some work looking at moderate and late preterm babies, and I'd highlight this because many of us are interested in doing things like salsa and stuff in bigger babies. And this group in France had demonstrated that outcomes such as a combination of PEEP and higher FiO2, where this sort of multiplicative factor of 1.5. So if you're on a PEEP of 5 at 25%, or a PEEP of 6, or sorry, a PEEP of 5 at 30%, or a PEEP of 6 at 25%, if you're not getting ahead of these babies by 3 to 4 hours and they fail, those are babies likely to do worse, versus if you have a score less than that, you might have better CPAP success. So there are groups trying to do predicted sort of models on both term and preterm babies. And Peter Dargaville's early work looking at an FiO2 40% was predictive of CPAP failure. And as you know, and I'll highlight this later, they used that in the Optimus trial as well, to try to optimize how CPAP was working. Now, when you look at the different methods of giving surfactant delivery, and I'm not saying these are all being routinely done, but I just wanted to highlight them as an introduction. When we talk about things like aerosolization, supraglottic airway device placement, pharyngeal installation of surfactant, or delivery via thin catheter, all methods. And you could argue, are they truly non-invasive? Probably not, but they are less invasive than putting an endotracheal tube into a baby's trachea and ventilating them for a period of time. So we're contrasting these, and this talk is not about Ensure. You'll see me sort of bring that up as a comparative arm, and we can spend time in the Q&A debating, well, is Ensure, because if I do it this way for 5 minutes on a ventilator, or if I leave it in the throat for a half an hour, that is, in my mind, still an invasive method of giving surfactant. Okay, so when we talk about aerosolation, I always felt like, and we were involved in some of these trials, that this could have been that holy grail. If we were able to give babies surfactant like we do nebulization treatments like albuterol, et cetera, this could really have changed how we practice care, and avoidance of ventilation, but also avoidance of instrumenting the baby's pharynx and all the harm that sometimes we see with intubation. Unfortunately, as you'll see in the next few slides, they've not sort of demonstrated benefit in the most immature infants. And just to sort of highlight, I have some nice videos that were given courtesy of Jan Mazzello of some babies in Poland. And you can see this is a baby that's on bubble CPAP and is able to get aerosolization through effect air, where the sort of bubbling and is able to swirl around the aerosol treatment and be able to deliver treatment to this baby effectively. This was one of the first trials we did with synthetic surfactant. And then the more sort of recent trial that was published was looking at almost like a pacifier, like a laryngeal mask type of airway that was put in the back of the baby's throat. And you could be on any mode of CPAP, whether it's BiPAP, CPAP, or even nasal intermittent ventilation for support, but then you could still deliver aerosol through the sort of posterior pharynx, as shown over here on the picture on the left. And so again, these were less invasive methods of giving it. But again, when you sort of look at the data, this was one of the trials that we were involved with in San Diego. It did reduce the need for endotracheal intubation by 50%, which is fantastic. But really, when you look at the gestational ages that show the most benefit, these are babies really above 30 weeks, and not the babies that we see a high incidence of RDS and even of CPAP failure. And so it argues that, why are we not able to affect the groups over here where we see high incidences of RDS? Is it the lung disease is too severe and we're not able to get surfactant into the distal airways because they're not ventilating appropriately or recruiting there long enough? And these are things that we're still trying to figure out even today, some ongoing work in that area. And then many of you might have known the study that was also conducted in Australia, similar thing where the overall effect was great. But in fact, when you look at the babies that had the benefit, it was not in the 29 to 31 weeks, but in fact, the babies that were 32 weeks and up that had the biggest benefit in terms of reduction in the need for endotracheal intubation. So moving on to other methods that also have been studied. Many of you might have seen or heard of this study by Colin McDonald, looking at pharyngeal administration, which again, physiologically could have made sense if you take a baby with that first gasp as they're being delivered, and then you put a syringe into the back of the baby's throat and squirt it in, even during things like delayed cord clamping and before the cord is cut. Can you then let that baby inhale with that first breath the surfactant and distribute it across the lung? And they tried this in 200 infants. There was no benefit. But one of the more concerning things, at least in my mind, is there was, in the secondary outcomes, there was an increased risk of pneumothorax of 16% versus 7%, which find quite high in that sort of population. And so maybe some plugging or asymmetric installation of surfactant that might actually be harmful. So to my knowledge, I don't know anybody that's taken this up. I find it's sort of harder to refine, and this was a pretty well conducted study. Then moving into laryngeal mask, again, I sort of use this term interchangeably with supraglottic airway, but these are both referring to the same thing, which is essentially a combination of any of these different devices you can see based on curvatures and sizes. The duckbill, what we call, or sort of the shape of how it fits into the posterior pharynx. You can confirm correct placement using any methods of these CO2 detectors or digital devices. And then in terms of placement, it's fairly straightforward where you're trying to insert it where it's covering the opening of the epiglottis. So then as that baby's starting to breathe, you can basically either through positive pressure breaths or letting the baby sort of inhale it, administer surfactant while maintaining your PEEP during the procedure. And there have been a number of trials, and again, this is just a high level. I don't expect you to be able to read all these studies, but a number of different studies that have been done comparing laryngeal mask airway to either Ensure or to sort of continued CPAP therapy. I just mainly wanted to highlight these studies are not sort of very large in terms of numbers. And if you look sort of further, most of these studies were done in NICUs in high income settings. So really not in the setting where they're low resourced, where LMA might be very useful in terms of placement. In addition, when you look at the different trials, most of them included babies that were around 1,500 grams, and very few of them used LMAs in babies less than 1,200. Now that is changing in the US. We have a device that goes down to 500 grams that was recently approved by the FDA, which is our governing body, but it has not been subject to any sort of large cohort, let alone in randomized controlled trial use. So I think we still need more data before we start using these in tiny babies and starting to give surfactants. So it's really, this tool is limited in a more mature population. And as far as the evidence goes, when you look at SALSA versus Ensure, I think there's a need for more data just because there is benefit. But then if you look at these confidence intervals, they're quite wide, giving very low certainty of evidence when you apply the grade criteria. And so the need for larger trials is necessary. And I'll highlight some of the studies that are hoping to address this uncertainty that we're seeing. So the one that many of you know, is the Surf's Up trial done by, sorry, my Zoom is being blocked here, but I think it's probably coming up on your screen, by Joyce O'Shea and Cullum Roberts. Peter Dargaville literally emailed me yesterday, and so this number hopefully is accurate because I think he sits on the DSMB or on the steering committee, but there's around 640 babies out of 1,000, so they're recruiting quite well, which is I'm very happy to hear, which will be the largest study of comparing thin catheter administration of surfactant versus a supraglottic airway device as a non-inferiority trial, and really potentially highlighting that if these two interventions work equally well, SALSA or LMA use is much easier to do and may become the method of choice. Sorry, this is freezing here. And then the other one, which we're starting, and I'm working with these two wonderful neonatologists, Charles Rohr and Carrie Roberts, is called the SPLASH trial, which is in late to early preterm infants. And we will be looking at 406 babies in an ordinal ranked outcome to see if we can improve how giving sort of early, almost prophylactic SALSA compared to expected CPAP management improves outcomes in this population. So again, two fairly large studies. I did look, there are some small single-centered studies going on as well that are sort of looking at similar questions, but to my knowledge, these are sort of the two large trials that will really, I think, help tighten up the certainty of evidence for SALSA use. Now, for the remaining of the talk, I wanted to spend a lot more time on LISA or MIST because there's a lot of good data out there. So for that first column, I think, again, highlighting that when we compare LISA to these other methods, just remember it's really been studied well, although the new trial in Australia will sort of move into older infants, but it's been mostly studied in extremely low birth weight infants with a good amount of data. But the barriers are, of course, laryngoscopy, and the McGill forceps have been a barrier, but I'll sort of highlight why that's been changed. And then when you sort of compare that to some of these other methods, such as the use of aerosol or LMA uses that makes it easier to give. But again, you have limitations such as the lack of benefit in small babies with aerosol. And with the LMA, again, you can't use it in small infants yet until we get more data. So I think we still have more work to do. And I've already highlighted the pharyngeal. So I think this sort of table gives you an idea of where on the spectrum we are. And I think most of us are sort of leaning to this first and third method as far as studying it more to be able to get better uptake in our NICUs. Now, just a quick history on thin catheter use. Again, many of you probably have heard these papers. There's some great review articles as well that have sort of highlighted that the first description of it, of a thin catheter use, although this was not part of the trial, but if in the methodology, you can see that a few babies in the Verter trial were actually given surfactant with a thin catheter while they were on CPAP. But really, I think most of us probably in the US and Australia and Europe really picked this up from the work from the Cologne group led by Angela Cribbs that has started to do trials looking at very early administration, even in the delivery room, of giving surfactant via thin catheter application, and then continued on since 2007. Now, the method of thin catheter administration is quite wide. If you look at a lot of the trials, they'll have all kinds of different names, but really they're all thin, soft catheters. But some of them do require McGill forceps and some don't. And I think to me, that's the game changer in terms of adoption by most neonatologists. The challenge I'll speak from, our country's experience in the US is we don't do nasal intubations. We only do endotracheal intubations. So many of you have probably done nasal intubations or definitely be trained in European centers. That's quite routine. In which case you're using a McGill's forceps to thread the catheter through. And that's made LISA sort of only limited to certain centers. And if you want me to sort of explain or show this more, I have a video in the next couple slides. But again, the catheter usage, you can see, is quite varied when you compare the size of the catheter to something like a 2.5 endotracheal tube, which many of us are used to. But these are all smaller diameters compared to those and different lengths and different sort of flexibilities. And the one that's really taken up is this Choice D, which is a 16 gauge vascular catheter that many of us have used and adopted because we can get them from our adult colleagues that are using them for cardiac catheterizations. So hopefully this will play. This is I'll make sure the video here is not too loud here, but really this is a YouTube video and the reference is up top. You can see the sort of struggles here while they're trying to do LISA with a laryngoscope in one hand and then the McGill forceps attached to a nasogastric tube that then will be inserted in the infant. To me, again, my mentor, Neil Feiner, training us to do endotracheal intubations in about 30 seconds. You can see how challenging it is when you're holding a laryngoscope in a baby for close to what in this video is over a minute or so long, and then eventually placing it. So all that sort of pulling on the baby's epiglottis and trying to get a tube in this baby, obviously it's quite challenging, and this gentleman does it quite nicely getting it in on his first attempt, but it's not a straightforward method. I contrast that really when you look at this is a mannequin. I had a nice video from Peter that he gave me earlier, but it didn't play on here. But this is one that he posted as part of the Optimus trial, so you can go on his YouTube and watch it. But basically, he's showing you on a mannequin that this is quite easy to do even while the baby's on CPAP. And again, it's the same method as far as inserting a laryngoscope, but you can see by having a semi-rigid catheter that's flexible and soft enough not to injure the epiglottis, but it can be placed pretty readily, pretty quickly, and in some ways almost more quickly than using an endotracheal tube because it's smaller, a little easier to place. The one thing he doesn't show in this video that we've really adopted, and I think many of you have probably looked into this, is using it with video laryngoscope. And I'll show a few slides at the end of the talk that have some data to support this, where now you can have confirmation that you're not only by the person putting the tube in, but sort of surrounding people that the catheter is in the right position. And I think that's made it a lot easier to use LISA or administration with a thin catheter. So the evidence for LISA, again, you can see this Cochrane, which interesting, Peter is a co-author on, but doesn't include the Optimist trial. There is another one, but it's not a Cochrane, that it has sort of similar effects, but I just chose to include this one just for the level of certainty. You can see here that even compared to Ensure, which obviously is a lot of people sort of debate whether Ensure really is LISA, but there are some differences which I'll get into. But whether you compare with Ensure or endotracheal tube with delayed extubation, the forest plots here all sort of, when you look at the diamonds, consolidating this has a pretty good effect size and a good certainty of evidence that you are reducing a number of these morbidities by using early thin catheter administration of surfactant. Now, getting into the sort of high-level evidence. Now, when you're looking at randomized controlled trials, there's none other than the Optimist trial that has really been the standard, I think, moving the needle for many of us in the use of thin catheter administration of surfactant. And here's the Peacock question, which is just comparing one method of giving surfactant, which was LISA, to then the continuation of CPAP. But then if those babies failed, they're intubated and mechanically ventilated and given surfactant. And they were looking at the outcome of death or BPD at 36 weeks of age. And this was published now almost 4 or 5 years ago. The inclusion criteria for this trial was, again, I will contrast this because it's a little bit different than the study we did, which was they required them to be on a CPAP level of 5 to 8, but they had to be on at least 30% oxygen. So you had to have enough equipoise that the control arm would continue on and not get intubated right away at 30% oxygen, but that this had to be in the first 6 hours of life. This is the only study, and I haven't even looking at new trials to date, no one has been able to take this on to be blinded, where even if you had, LISA or MIST done on the infant, you would place shams around the bed space and cover it up so nobody could see what procedure was happening, but somebody could see the monitors, and so you could monitor heart rate and oxygen saturations. And they had a sham group that only was sort of repositioned, and they did this on every baby in the trial, whether it was on days or nights. So kudos for the effort to do that. The flip side of all that, you do good science, then the limitations of that is pragmatism, where they had close to 4,000 babies excluded. Now, a good number of them were intubated, but another good number of them were not within the threshold of needing 30% oxygen or more in the first 6 hours of life. And I will tell you, having been involved in surfactant trials or doing our own, oftentimes babies don't often hit the threshold right away. They gradually go up. But in this study, if you didn't make it within that first 6 hours, you were not included. So you had to be right in that sort of sweet spot to be in the study. So ultimately, they had 1,200 that were eligible, but of those close to 1,200, they had several ones that were not, for things like a refusal of consent, etc., that were not included. Ultimately, there were just shy of 500 babies in the trial, and when you sort of look at the outcomes, they were able to reduce BPD in infants from 45 to 37%. When you look at some of the other outcomes, on the non-binary outcomes like ductal treatment, intubation at any time, etc., those were also significant as well. All sort of focusing on when you do early LISA MIST, you are reducing the need for intubation of these babies with the resultant benefit of BPD, which we're always trying to achieve. So this trial, obviously, to date is the largest trial to date. But what I didn't talk about was the trial happened during COVID, which many of you know that whether you've done trials or taking care of patients, it made everything extremely difficult. But it was stopped early. And it wasn't stopped early for harm. It was stopped early really for futility. It had been going on for almost 10 years. And so we know with any trial, if you stop early, you may see an exaggerated treatment effect. So continued enrollment, would have that reverted closer to the null? We don't know, but that's always a limitation. And again, as I mentioned this, there were many infants excluded. So when we think about our own practice and how we're using early surfactant or sort of pseudo rescue surfactant, it may be different than the criteria we used in this trial. And just to highlight, and the authors did a nice job explaining this, is that there was an exploratory subgroup, right? Because you saw death prior to 36 weeks was slightly higher, because if the composite wasn't different, but BPD was, death must have been slightly in the wrong direction. And they saw higher mortality in infants 25 to 26 weeks in the MIST group. When they looked at that group, there were more males that didn't get steroids, etc. So again, when you're starting to slice and dice different subgroups, you might see things that may or may not mean anything. This may not say that, males who don't get steroids will do worse with MIS. It just says that when you started looking at different groups as to why you didn't see a benefit, there was this handful of babies that did not do well with it. Now, they recently published their long-term follow-up study, which I wasn't going to get into too much. The primary outcome of neurodevelopmental impairment was not different, which we see in almost every neonatal trial to date, but they did show benefits in terms of hospitalizations for respiratory illnesses, suggesting there may be a potential lung benefit that's longer term that is maintained by doing early LISA mist in these infants that may not necessarily relate to neurodevelopment. On the flip side, too, I like to focus on the lack of neurodevelopmental impairment with LISA because of this concern of laryngoscopy. Of course, laryngoscopy is not benign, but at the same time, in these groups where we're not pre-medicating them, and we can talk more about that in the Q&A, it's reassuring that you don't see harm in a group that you're giving more or exposing more babies to laryngoscopy in one group compared to the other. This is just to highlight really how behind, I guess, we are in our country. Again, we use the term LISA versus MIS, but they're interchangeable. And really, when you looked at this survey, this was now 6 years ago. I hope we have a new one, but very few neonatologists in the United States were recommending LISA to be standard of care. And so I think we're still needing more evidence, and hopefully I'll get some more data that will really highlight that these numbers are improving. Getting into our thought with doing LISA in the trial that we did, we were really interested in how the German group was using LISA at the time. And that was really that they were doing it in the delivery room, but they're also putting IVs in the delivery room and giving caffeine as part of the overall strategy to maintain spontaneous ventilation. Now, in the Optimus trial, it wasn't that you weren't giving caffeine per se, but it wasn't sort of timed at the time of giving LISA, particularly if you're giving it very early. We oftentimes have to be prescriptive if we want to give it at the time of its surfactant administration. And so we wanted to look at that combination therapy to see if we could sort of mimic what we were seeing in that the German studies to date. And just a quick one slide on caffeine in terms of my personal interest and what I've seen sort of caffeine do compared to placebo in some trials. We did an early caffeine trial in San Diego that just showed some hemodynamic benefits. There was a trend for less intubation when we gave caffeine right at admission versus 12 hours of life. Now, again, that study, this was 10 years ago. Now we're giving caffeine, all of us, sort of right after NICU admission. But the group in Leiden also, led by Anup Paz, showed that babies who get caffeine in the delivery room compared to in the NICU had better respiratory function when you looked at things like their tidal volumes and a number of breaths that had tidal volumes above 8 mils were higher in these babies that got caffeine. So clearly it's a lung stimulant. It promotes better lung dynamics compared to just letting the baby transition on their own. And so with that sort of thought in mind, our trial, or our PCOT, was looking at caffeine followed by LISA as the intervention versus just giving caffeine, also trying to give it early at the same time, but continuation of CPAP to see if it reduced endotracheal intubation in the first 72 hours, very similar to many of the LISA trials that you've seen. And our inclusion criteria, I'll highlight why these are slightly different than the Optimus trial in a few slides, but we were really looking to give it early. And again, we can talk a lot about the biases here with early prophylactic, I guess I sort of use them in the same vein, versus rescue, which is I'm waiting until the baby's on a certain FiO2. And to me, this gets into when you're timing in terms of avoiding CPAP failure, what's your goal? My unit and the way many of us in Southern California practice, sort of our state, really push to give surfactant soon after birth, many times in the delivery room. So the trial was sort of designed it with that in mind, that a number of these babies were getting it soon after birth. And in order to do the trial, we did not have the budget to do a blinded study, but we tried to maintain strict criteria for intubation using some of the European consensus guidelines for intubation. So if a baby hit any of these criteria, they were counted as intubation for the purposes of our trial, whether they were actually intubated or not. So I'm not going to read all of these here, but I think you sort of get the overall gist. And then this is our cohort diagram. Again, it was randomized to CPAP or LISA. The majority of babies received the intended treatment, as you can see here. So we didn't have too much in terms of protocol violations. And the groups were fairly balanced. Again, as you'd expect with any study with antenatal consent, high steroid rates, good prenatal care, all that sort of thing. And even though we gave surfactant fairly early, even in the delivery room, one would argue, well, were they that sick? Our average FiO2s were somewhat similar as what you'd expect with babies that get surfactant therapy, around 35%. A few of them had, a third of them had FiO2s above 35%. But these weren't also very sick kids. You could see their cord gases as shown below. Our primary outcome was the reduction of intubation. As you'd expect, like most trials, if you give surfactant early, whatever the route is, Lisa, etc., you are able to reduce endotracheal intubation. But it also gave you an idea of how many babies, even in the expectant group, were actually intubated and given surfactant. So even though we reduced it by half, only about half the kids in the expected group were intubated. When we looked at some of the other neonatal outcomes, such as BPD or death, it was reduced, although our trial, I would argue, it was mostly grade 1 BPD when you broke these subgroups out. But the nice thing for me, at least having done this our first trial and bringing more Lisa to the US, is we didn't see harmful effects. We didn't see more air leaks or other adverse effects with giving early prophylactic Lisa in the study. And then when you look at it by gestational age, it didn't really matter what gestational age you were, that it sort of trended to have benefits. It's shown in the blue bars here, with the red bars being CPAP, but it wasn't that unlike aerosol where you didn't see benefits in the small group. It looked like even the tinier babies, we could offset intubation in every gestational age. And similarly, it held true with BPD as well across gestational ages. So reassuring in that regard. Now, some of the limitations, we did see a statistical difference of caffeine by like 20 minutes. It wasn't a huge difference. The majority of babies were given caffeine within the hour. And we did do an effect modification to look at whether early administration had an effect, but it did not. And again, we were unblinded. That's going to be the biggest limitation of a study like this, that clinicians knowing that the CPAP group was not given Lisa, would they then choose to intubate those babies? And so we'll always have that as an issue in any unblinded trial, that only the Optimus trial was really able to avoid confounding. Recently, I haven't published these, but it's under peer review. We looked at 2-year Bailey scores in babies that were in the trial, and we didn't see any differences. Again, as you'd expect with cognition, no differences. I had hoped to maybe see some differences in some of the respiratory outcomes based on the Optimus trial, but we did not. The nice thing, though, is, again, if you have a small study, at least from a directional effect or looking at sort of the point estimates, everything seems to be pointing at least for less of these harmful morbidities in terms of things like gut and hospitalization or even moderate severe NDI. They're all in the direction of favoring Lisa. So at the end of the day, when you start adding more and more of these Lisa trials or MIST trials that have follow-up, which we're always interested in, hopefully it will continue to point in the direction that this is a safe and potentially efficacious intervention for babies even after the NICU. And then I just wanted to do a comparative slide that, these trials are different, but in some ways are also similar gestational ages. We didn't include intubated babies, but we have some differences that our trial was unblinded. We gave surfactant very early. I think Peter calls our trial more of a prophylactic study, which I do agree with. We did require caffeine. It's not that they didn't in the Optimus trial, but at least can say with certainty that every child was given caffeine before Lisa was attempted. And again, our thresholds were a little bit different in terms of intubation and entry criteria. Even despite those differences, when you put the studies head to head, I really look at these cumulative intubation curves. They're pretty similar in terms of, by around 12 hours, when you're looking at separation between the group that kind of sustains itself. Even in a blinded trial like Optimus compared to an unblinded trial like the Cali trial. That to me was fairly reassuring. And even when you put these studies head to head in terms of the forest plot, the bottom one is the Optimus study and the top one is the Cali trial. Again, we both sort of had similar effect sizes when we're looking at things like BPD or the need for intubation in these groups. So those things were, I think, reassuring and looking at where the level of evidence is for Lisa MIST comparing to doing expected CPAP management. All right. So just a few more slides I wanted to highlight just to get into some of the nitty gritty with Ensure. I want to give you both sides. I think, in our proponents for LISA are missed. When we talk about it physiologically, is spontaneous breathing better than giving surfactant with positive pressure ventilation? And so the argument has been that, when you have glottic control, the vocal cords can close around the catheter versus you sort of controlling how surfactant is going into the babies with positive pressure breaths. And obviously, we know positive pressure ventilation is harmful. We've seen that in early animal models for years. The other side of it, too, is that small babies, at least in the Italian sort of cohort, looking at Ensure, tend to fail babies under 750 grams. And we're not seeing that with LISA. And we know from some of the German trials, they included babies at 22, 23 weeks without any sort of problems in terms of failure rate. So this is the sort of reasons why LISA may be superior than Ensure. On the flip side, there's this nice review paper I put at the bottom by Dr. DeLuca that there might be concerns that LISA is not necessarily benign in terms of the procedure. Side effects of desaturations, bradycardia, surfactant reflux have all been reported in a number of these studies. And when you look at the size of a LISA catheter, and this is a nice figure that they have in their paper, in the preterm neonate, it's very different than putting a catheter in a term baby or an adult that's getting a flexible bronchoscopy. There's not a lot of room, for the baby to breathe around per se. So the cords may close around it, but can the baby effectively breathe around this? And this is an argument that they have made that may not truly be what we think it is in terms of aerating around the tube. The other big issue is pre-medication. Is pre-medication okay for babies with LISA? I would argue we tried to do the opposite. We gave them caffeine. We wanted them very awake and breathing a lot. If you are giving them too much sedation, you might have to give a lot more positive pressure ventilation, which may in fact negate the benefits that we would see with LISA in surfactant distribution. And this is where I was highlighting some of the benefits, the reasons we need long-term outcomes. Again, the German cohort showed an improvement in long-term outcomes, again, not in the randomized control trial, but in their larger cohort studies in the German neonatal network, that this, even at school age, has been beneficial in babies. And the question is, yes, avoiding narcotics may improve LISA, but the cons of not giving them something for pain. A lot of what's been brought up is things like using sucrose or sweeties, we call them in the US, to try to and then doing swaddling maneuvers. Is that enough for these infants? When we looked at pre-medication in some of these studies, this is a nice study out of Poland, demonstrated that when you gave pre-medication, you had 9% of them having apnea, but giving something like glucose gel versus no pre-medication are probably quite similar. It might be another useful alternative. Another study looking at doing propofol, and this is in the group Enlighten, demonstrated a number of babies needed PBV, developed hypotension, bradycardia, etc. So probably not an ideal choice for pre-medication as well in doing LISA or MIST. The other thing I had mentioned earlier was the use of video laryngoscopy. I think many of you probably are doing this routinely, or at least looking at it for maybe difficult airways or for trainees. I think many of you probably know that from the SHINE trial that demonstrated benefits with video laryngoscopy. And so there are many studies that are showing benefits of avoiding multiple attempts, but it's definitely useful with LISA where you can document that the baby has the tube in past the cords, and you could visualize it by multiple people. So I think that's really helped. But as you can see in the study, they were able to get very good success with video laryngoscopy routinely being used. Just for the last few minutes, I think I have a couple more, and then we can talk about during the QA, what are some of the trials that are up and coming. So this is the Nona LISA trial, and I have some of the protocols that are published in the references below. That's looking at, a non-pharmacological approach. Is that better than giving pain medication? So the intervention is placebo versus the control arm is getting fentanyl during LISA, and to see whether or not that is there an increased need for invasive ventilation, mechanical or intubation with for at least 30 minutes in the first 24 hours. So if the baby ends up needing any PPV, they're counted as failure, whether they're intubated or not. So you could argue, well, is that necessarily as bad? But they're looking at enrolling 324 babies in the trial, about a 15% absolute reduction. And then there's the Pro-LISA trial, which is looking at in preterm infants that are on less than 30%. So they're really trying to focus on prophylactic, getting into that group that's at high, avoiding the group that's at high risk of CPAP failure. If I do LISA very early before they've achieved that higher FiO2, does that work better than the continuation of CPAP or CPAP failure? Very much like the Optimus trial, but they're focusing on probably a meaningful and more biologically plausible pulmonary outcome by looking at FEV1 at 5 years of life. So looking at pulmonary function in about 700 babies, and that's by Dr. Gopal, who's done quite a bit of work in the LISA mist space. And then a couple more. This is one out of China, looking at less invasive surfactant using this LIPSA approach, which essentially is saying if I do ensure with lower peak positive pressure, so it's almost like I put the tube in and I don't do high pressures. I don't pips of only 12 to 15 centimeters of water and a high rate of 40 for 5 minutes and then take it out. It's a very well-defined ensure, almost like the ensure that really the French group has talked about using high frequency, a very detailed method of doing ensure, and compare that to LISA. Is that better reducing the incidence of EPD at 36 weeks? And they're looking at 258 babies with a 5% absolute reduction. So we'll see what happens there. That's ongoing too. So this is my sort of take-home slide. I think at the end of the day, LISA mist has promise and has shown benefit in several trials. And we have now the Optimus trial, at least one double-blind study. So I think for the most part, many of us have established this method as the ideal choice of lesser, or I would say minimal, probably the right term is lesser invasive methods of giving surfactant data. That there's still nuances around there. There are groups that I know of that are using pre-medication. I'll use a half dose of fentanyl or morphine, but I think we still need more data. And ultimately, the more long-term data we have, I think we can settle some of that debate. And then I think the supraglottic airway or LMA use in small infants will change how we give surfactant, but we do need studies. I don't know of any to date. I've talked to many investigators who are looking at this question, but if we can put a device that small in a baby, in a 500 grammer and give surfactant, well, now you don't have to instrument the airway as much. It's much easier to do, but we still need to be able to show that it works effectively. So I just want to thank my research team and all of my sort of LISA collaborators in the US, and obviously my mentor, Neil Feiner, who's been really instrumental, and then obviously KZ that sponsored our 2 trials. So I think I'm at 15 minutes left. So
yes, excellent, Anup. Great overview of this topic, because there's so much said about surfactants, but the way we administered it is coming up in the last decade. You gave us a great overview why this might be important, and I think that was an important message. That CPAP failure babies. Did we pick the wrong mode of respiratory support from the start, and can we select those babies? You explained a bit about the 2 to 4 hours window, I think was important. And then you went to all these methods of administrations, all the pros and the cons. You gave us the data, and then you explained the studies, which I thought you did it from a trialist perspective. And I hope now during the discussion, we can have it from the, clinician's perspective of how to approach that. I really loved your slide about Insure versus LISA and the biological plausibility, because I don't think I've seen much. I've heard Danny talk, and you're like, come on, how is that any? Come on. So I really like that particular slide, which yeah, actually, there's something to say for that. So let's go to the Q&A. Put your questions in the QA. There's one question here, Samuel Desai from Western Australia, with the Cali trial. He said there was no strict FiO2 requirements. So what was the surfactant criteria for the CPAP arm?
Right. No, great question. So both groups, And I struggled with when we designed the trial, we wanted the opportunity for clinicians to give surfactant in the delivery room. And FiO2 cutoff in the delivery room is very tricky. As you guys know, many of us start at 30%, but we yo-yo the FiO2. So we said as long as the baby, um, from the clinician standpoint in the intervention group was stable enough to receive surfactant, that was fine. But I think this question's in the control arm, the CPAP arm, the threshold, as you saw, I had that in the sort of the bottom third of my slide deck. They needed to be on greater than 35% FiO2. So one group got it very quickly, which was the intervention group. And the other group had to sort of trickle along and fail based on what our sort of clinical criteria are. So you could argue one was rescue and one was sort of a prophylactic group.
Maybe before I go to Dr. Biswa's question, I'll follow up on that one. So a lot of these LISA trials, they are actually earlier versus later surfactant.
I think that's right, Kurt, because I think one of the criticisms are, well, why can't I just intubate the baby in one group versus the other? And we've seen that the early trials, people, and you probably remember these, is that the early studies of prophylactic surfactant weren't bad. I mean, they actually reduced morbidity. They reduced pneumothoraces. We saw, less benefits or better, sort of better benefits and sort of quote rescue. But I think we're flipping it on the side now that we know that CPAP alone, that's not what was compared in those early trials. It was not, it was now that we have CPAP is better than any intubation at all. And we're sort of having to go back and say, okay, now what's the right approach for these infants? And the struggle, like I said, with Ensure, at least this is our bias, and we can debate this, is you put the tube in that baby, it's hard to just pull it out. Many people sort of don't have enough strict criteria. So proponents of Ensure said, well, in my hands, I never ventilate that baby more than 5 minutes, so that's not mechanical ventilation. I would say, great, kudos to you. But in my unit, when we've tried to do Ensure, people are ventilating the babies a lot longer. There's not strict criteria on when to do that. LISA or MIST-U, there is no way to continually mechanically ventilate those babies. And I think when we're trying to compare these things, it's absolutely a comparison of early surfactant versus rescue, but it's the method, I think, that we're sort of talking about in avoidance of ventilation that I think we're seeing.
Dr. Biswas has a question about pre-medication, which we can continue on, but this one is specifically on atropine. What do you think?
Yeah, I think atropine's a great drug. You're going to avoid bradycardia, and for rapid sequence intubation, we use atropine first, followed by fendel plus or minus a paralytic. In this case, if you're trying to avoid any sort of effects on breathing, atropine is not going to have any ill effects on breathing. So you certainly can. Some of us have talked about, particularly for SALSA or LMA administration, sometimes the cords cause sort of reflex bradycardia, or you get this sort of pseudoparalysis of it, and having atropine, will that allow some stabilization of it? So we've gone plus minus on atropine use, but it's not in my unit you routinely use, but I don't see any downside. In fact, the other nice benefit of atropine is it decreases secretions. And so you might actually see a benefit as you're going in to be able to visualize the cord, seeing less of, all those, bubbles and saliva that kind of mess up your view on those infants.
Kelvin Mitch, I think it's more of a comment about catheter placement and conferment with capnography. Do you use that?
We don't use capnography. We use a CO2 detector, just a PDCAP colorimetric CO2 detector, which I think works quite well so I'm sorry, we don't use, this is for LISA, right? For mist placement.
Looks
so
like
yes, we haven't, but I know what you're referring to, where you can put the catheter in and aspirate air through the CO2 detector to be able to see if you're actually getting exhaled CO2 from the lung versus the stomach. And I know in the US, Ram Ramanathan in Los Angeles has been using it and demonstrating that with using sort of a Y piece where you can aspirate it from the catheter. I guess I would argue in our trial, we didn't have any babies that had sort of surfactant in their stomach afterwards, or we didn't confirm placement. There's even a group using ultrasound to confirm placement of the catheter. In my mind, I'm in there for about a minute, I remove it, and then I'm done. I don't sort of see the bigger value of confirming each time, but if you've had a bad experience or you're worried that people are going into the stomach repeatedly with the catheter and you need to confirm that, then I could see why you may want to use capnography or some method of CO2 detection for Lisa or mist. But I would be surprised if that's going to become sort of mainstay for this procedure.
Now, and he also mentioned that video laryngoscopy is used, and I think that is, to me, it is so helpful to stand behind somebody
Absolutely.
and we go like, yeah, 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 you're good. You
Right.
just do it together, and we didn't used to have that back in the day. So I think that it will be the way forward. I like this question. Dr. Visritan asks about other surfactants. I know Chiesi, Chiesi, Chiesi. But what
Right.
is with all the others, and what happened to all these synthetic surfactants?
Yeah, I mean, that's a great question. Again, I don't have any partiality to our unit uses that one surfactant. The differences would be, without getting into obviously the different amounts of, surfactant protein components, but really volume is and the sort of viscosity, I think are clinically the things I see that are the difference between, CuraSurf, right, KZ or InfaSurf. Is there another one that's popular in Australia? Because I apologize, I didn't actually do my research. But the InfaSurf is larger volume, but it's thinner, so it's it's less viscous. So some may argue that may be. I've used both in my practice before, but my current hospital just uses the one, and so you just have to be mindful of the differences in volume and sort of that viscosity issue of whether that's a problem or not. But I think you can use absolutely either or any surfactant for these methods that I've been describing. And I think that's a good point. I should probably mention that these studies, even if they all, I think actually I'm pretty sure the Optimist trial was also using only CuraSurf, and I think almost all the Australian trials that I know of, the Plus trial, yeah, it's been mostly using a component of CuraSurf, but I don't think there's an issue, to be honest.
And about the synthetic surfactants, what is going on with that? Is there something happening?
No, it's to be honest, I think it's dead. They tried multiple companies to take on the synthetic surfactant. The aerosols, it got bought out, repurposed. I've not seen anybody take off with that. So I would probably
No, no,
say it's
it stopped.
gone.
I agree. It stopped at some point.
Yeah.
Reports and things stopped, and Chiesi took over the world. That's basically what happened. A follow-up question from Samuel. Wouldn't the timing of surfactant be a major factor in influencing the need for ventilation and BPD than the method giving surfactants, so Lisa versus Ensure? Was that factored for in the Cali trial?
Yeah, we didn't because we couldn't adjust for it in the trial because everybody got it early. But yeah, I honestly believe, and if you talk to many, pre-support and coin trial where many of us were giving surfactant early, I think we, whether it's anecdotally or the older data, show that it worked well. So why wouldn't it be? I think it could be. The question, we don't have a way to in these trials to really adjust for it, but whether you gave it in the first hour in the delivery room, like in our trial, or you had to wait till 4 to 5 hours to give it in the Optimus trial, they both seem to have worked well, but that is much earlier still than I think what many of us think of rescue for surfactant is that baby that's sort of flailing along is past 6 hours, 12 hours, now is on CPAP of high levels, still needing 40, 50%, and now you give it. I think we all know those babies are not going to respond as well and maybe are more likely to have BPD. And so are we going to see less of a benefit than if we had given it early? The downside is, right, you will be overtreating, and I will say this very transparently, our trial probably overtreated a number of babies. But overall, and if you're giving it in a less invasive method and not ventilating them, I think it might be okay. And I think that's the question we have to ask ourselves, especially when we moved into things like LMA use and all that. Is it all right if a few babies that might have transitioned within a day or two get it? We'll try to be more precise, but if you're overall reducing these morbidities in these babies, I think it might be okay. But that's something you have to sort of ask yourself. Your unit, are you doing very well with low levels of CPAP failure? Then maybe that's not for you. But if you're in a unit that has babies that do poorly when they fail CPAP and you have a high incidence, I think you need to think about giving it early in most of these kids.
Yeah. And this is a translation here from trials to your own clinical setting. I think it's
Absolutely.
really important to do an audit in your own setting We did an audit back in the days where we did prophylaxis surfactant in 28 and 29 weeks. We actually found it increased the rate of BPD.
It
Sure, it was
did.
mostly
Okay.
grade 1, so we actually moved away from that particular approach. And
Right.
each setting is different. We all have different babies, and I think you need to explore that, what works best for yours, but usually by just auditing and before and after and see what happens. Would you agree?
I would agree. And the caveat of your point in your unit, Kurt, is to think about that gestational age, right?
Mm.
We tend to move towards, in my unit, early prophylactic LISA in babies under 26 weeks because we feel that those babies, even if there's a subset of them that would have done great on just CPAP alone, we're sort of weighing the harm when those babies don't do well. A 29 weeker who may end up needing surfactant late may not and probably won't get BPD per se, but maybe will be on the ventilator longer if they get intubated at a day or two. But that may not be a bad thing. And I think that's what we have to weigh when we're thinking about these subgroups is which group in your unit has the most CPAP failure that does poorly. And is that a group that moving towards a earlier administration of surfactant might benefit? So
Well, and there, is indeed the crude methods we have. FiO2. I'm always a bit disappointed. Is that it? Is that all we have? Anything else you think we should be adding if it comes to this earlier versus later selection of babies?
yeah, I mean, I do think some of the groups, like I showed you that one French study that did a nice job looking at a composite of CPAP and PEEP. Some of the studies we've been a part of looked at sort of these early Silverman indexes. So looking at these babies are really having a lot of pulling to breathe. That might be an earlier sign before they end up going up on their FiO2. There have been other bigger population type studies looking at, well, babies that have, early acidosis, multiples, et cetera, are those better candidates to get ahead of and give surfactant sooner? But I think at the end of the day, sort of picking a gestational age cutoff and sort of focusing on them and having a lower threshold in those groups, as far as FiO2 and PEEP might be greater. I know in Australia, a lot of great studies have come out from your groups using very high PEEPs. And so in that case, you do want to have a composite. If I have a baby that I manage on a PEEP of 10 or 9, that baby may not have a high FiO2, but may have significant RDS. So I think you need to put them together. And I think that's helpful as well.
Yeah, no, I totally agree. What about the use of lung ultrasound? Is that something which is used in San Diego?
Well, we're starting to with this new study. Our fellows and trainees love it. This is like a hot area for people wanting with POCUS. So it's not. I'm not at a point where I'm using the lung ultrasound criteria to have trial entry, but we're certainly using it for following babies. And Doug, I know I followed his work a couple of years ago when he was doing it very early to predict RDS. I think that's coming. I just haven't seen a trial. None of the ones I showed you, for instance, are using that as entry criteria. Like if your lung ultrasound score is 8, you're in the study, and I don't care what your FiO2 is. I haven't seen that, but I think it's coming, Kurt. I do think it's an important
No,
tool.
no, no. I think it's more than coming in clinical practice. When I talk to people who are doing lung ultrasound, they are using it to select babies combined with the FiO2
Yeah,
gestation
right.
rates and all things together. And I think I use it myself. I think it's a really elegant way of
Yeah,
selecting. Should we just do it now or should we wait? And it's
right.
slightly bigger babies who benefit more than the very small ones.
I agree. I
Anyway,
agree with
yeah.
that. Yeah.
Charles had the same question, lung ultrasound and placing of timing. So I guess any more questions for the audience to Anup? Otherwise, come meet Anup in 2 weeks' time in Melbourne. I'm unfortunately not going to be in Melbourne, but you will see many, many people there. Thank you so much for staying and for speaking to us and doing this particular webinar. I thought it was awesome and very, very good overview. So thank you very much. For the
Absolutely, Kurt.
audience, thanks for attending again. Next week, we're going to do John Faneroff. He is a neonatologist who talks about medical legal issues, which is really close to my heart. And I really, it's something very different, but something we need to know a little bit more about, I think. All right. So thanks, Anup, and have a good travels. See you in
Thank
Melbourne a
you.
bit later. Thank
All
you.
right. Take care. Bye, everybody.
Bye-bye.